Thank you for joining us today for our Lunchtime Health Sciences webinar, Weight Bias and Stigma, Bust the Bias, delivered by Sarah Miller, Registered Dietitian. I'm Jennifer DeBaker, and I'm the Health Sciences Programs and Partnership Coordinator. Before we get started, we'll do some quick welcomes and introductions. Reminder about your microphone being off for the duration of the webinar. The webinar is being recorded today and will be posted to our YouTube channel in the future. If you have any questions throughout the presentation, please feel free to put them in the chat. And we also will have a question and answer period at the very end where Sarah will address any questions that you may have. All of our previous webinars are now on YouTube, and you can find those links to those recordings on our RS and NODIP websites in the resource section, or they are also available on the NOSMU TV channel on YouTube. We want to start by acknowledging the land upon which NOSM University is located, to raise awareness of Indigenous presence and land rights, and to acknowledge the colonial history and current history in Ontario and Canada as a whole. NOSM University respectfully acknowledges that the entirety of the school's wider campus of Northern Ontario is on the homelands of the First Nations and Métis peoples. The medical school buildings at Laurentian University and Lakehead University are located on the territory of the Anishinaabe Nation, specifically Atikameksheng and Wahnapitaea and Fort William First Nations. We humbly ask that wherever you're calling in from today, that you think about the land and areas where you reside. Our speaker today is Sarah Miller. Sarah is a registered dietitian and clinical team lead with the Regional Bariatric Care Center at the Thunder Bay Regional Health Sciences Center. She's a lecturer with the Division of Clinical Sciences, Nutrition, and Biochemistry with NOSM University. She is currently pursuing certification as a bariatric educator and will be writing her exam in November of 2022. Sarah has been working in nutritional management of chronic diseases for the past 20 years, but has found the area of obesity management particularly interesting, challenging, and rewarding. She is also the hub leader and team member for education for Project Echo Bariatric. So merci beaucoup, miigwech, and thank you. Sarah, thank you for joining us today. We truly appreciate you sharing your knowledge with us, and we are looking forward to your talk and the opportunity to ask questions. And now I'm just going to change my screen over. All right, everyone can see that? Sarah, I know you can't see. Mike, can you let me know? All right, we're good to go.
Yeah, thanks so much. So Jen, do you want me to just indicate like next slide so you can advance it for me?
Absolutely, thank you, Sarah.
I'll let you know. Perfect, thanks so much for the introduction. I am very happy to be here even after a bit of a rocky start. I was looking forward to being with you a little more virtually today. Even cleaned up my office here in order to be a little more presentable, but c'est la vie, that's how things go sometimes. Again, I'm very happy to be here with you today to speak on this topic. My passion for this continues to grow, and I'm happy to share my knowledge with you. So next slide, please. In terms of disclosures, I got this idea from Angela Alberga, a PhD and researcher from Concordia University, who recently presented on weight bias and stigma at the 2022 Canadian Obesity Summit earlier this year. She notes the importance of acknowledging our personal biases because they can influence our attitudes and behaviors, and that is why it's important to increase our awareness. It's also important to note that we all have personal biases about all kinds of things, not necessarily just in the area of weight bias and stigma, whether we acknowledge them or not. So in terms of my personal biases as a registered dietitian by training, I do believe in the positive benefits of healthy eating, as well as promotion of and support for healthy lifestyle behaviors, particularly in the context of chronic disease management and prevention. I have not personally lived with obesity, but I have worked directly with many, many, many patients living in larger bodies and with obesity, and I have seen and heard firsthand their experiences with weight bias and stigma, as well as discrimination from family, peers, and unfortunately healthcare providers. And I do bring that kind of knowledge and experience to you today. I believe that weight bias and stigma is harmful to a person's health, and I believe in evidence-based science to help reduce the prevalence of weight bias and stigma in our society. Next slide, please. I want to further acknowledge Angela Alberga, as some of the slides that I'm using today were inspired by or adapted somewhat from her presentation that she did earlier this year, as I mentioned, at the Canadian Obesity Summit. I also want to acknowledge the clinical adult Canadian clinical practice guidelines, specifically the chapter on reducing weight bias and obesity management practice and policy, and we will talk a little bit more about the guidelines a little later. But it is where I got a lot of the resources, references, and again, knowledge I bring to you. So next slide, please. In terms of learning objectives for today, I'd like to define, contrast, and discuss weight bias, weight stigma, weight-based discrimination, as well as introduce you to internalized weight bias. If you're not already familiar, it is sort of an emerging concept under the idea of weight stigma and bias, as well as explore the prevalence of weight bias, particularly in healthcare, the implications of weight bias and stigma to patient and client care, and the impact or potential impact on health outcomes. But foremost, I'm hoping to leave you with some practical strategies to help reduce weight bias and stigma, particularly in healthcare settings and within your healthcare teams. Next slide, please. There are many myths surrounding obesity. The prevailing misconception is that body weight is entirely within one's individual control. People living in larger bodies are often characterized as lazy, lacking willpower, unmotivated, sloppy, overeaters, inactive, and as having poor self-control. The reality is that obesity is a complex illness caused by a number of different factors, including genes, environment, epigenetic changes, psychological and emotional health, medical problems, and even some medications. And so as much as I would like to provide a comprehensive examination of the factors contributing to obesity, it's not within the scope of our topic today, but I am able and willing to speak in the future about this important topic as well. The other reality is that obesity is not going away. So rates of overweight and obesity and chronic health disease are only increasing in North America and worldwide, and so it is an important health issue. Next slide, please. So these myths and beliefs that we have are the basis of developing weight bias, which refers to having negative attitudes towards and beliefs about others based on their body weight, shape, and size. This may come from our very early socialization by parents and caregivers based on their beliefs, right up to and including how we are trained in our specific areas of specialty by mentors, educators, and even work day-to-day with other team members and colleagues. Weight stigma is the labeling and generalizing stereotyping of individuals based on our biased beliefs of their body weight, shape, or size. Weight bias and stigma are very deeply ingrained within our societal culture and is not easy to change. Weight-based discrimination is acting on our personal beliefs and treating people differently because of it. This can cause social exclusion, inequities, and marginalization of patients in larger bodies. Examples of unjust or inequitable treatment or discrimination include health professionals spending less time, having more insensitive or rushed communication, or establishing less emotional rapport with patients living at higher body weights. This can also include denying service, treatment, and procedures based on a person's weight, body shape, or size in the absence of research or evidence showing rationale for doing so, and in extreme cases, denying life-saving treatments. Next slide, please. There are different forms of weight bias. Some people refer to it as ways of measuring weight bias, and so explicit weight bias is the overt mistreatment with words in our words and actions. And so these statements were modified from the anti-fat questionnaire, which does date back to 1994. However, these results have been duplicated in other studies as well. But this was sort of a landmark study in this area. So statements such as, I don't like people with obesity very much, I don't have friends who have obesity, although some people with obesity are surely smart in general, I think they tend not to be quite as bright as people without obesity. Some people have obesity because they have no willpower. People have obesity pretty much through their own fault. Does sort of sum up the main beliefs, again, around obesity. Other examples of direct patient experience that have been shared with me directly, I'd like to share with you as well. Patients have shared that they have been accused of being dishonest on dietary food records because they just don't add up, or they are lacking outcomes of weight loss as sort of defined by, say, the dietitian. Any dietitians in the group today or participants today may be very familiar with the use of dietary food records for a variety of rationale within the context of a nutrition assessment. However, this has been very damaging to the reputation of dietitians, and I do hear that, unfortunately, from many patients. An even more extreme example actually occurred within the last few months, where a patient described being denied hernia surgery by a local surgeon due to her size, and she was actually explicitly told, quote unquote, that she should be hogtied to a bed and starved. And so this, again, from a local seasoned surgeon, is a very extreme example of sort of the audacity of sort of comments that are being made. And although this is an extreme example, there are many examples of patients being denied joint replacements, hysterectomy, hernia repair, or skin removal until they lose more weight. Again, usually an arbitrary number chosen as a target that lacks evidence to show justification or rationale for the weight target or the denial of the service in general. It's also important to note that many of these experiences have been shared from patients who have undergone bariatric treatment or surgery and have already lost a significant amount of weight. It may not be realistic or safe for them to lose more. So this is the unfortunate reality, even for patients that have undergone a treatment for their obesity and have reduced a significant amount of expected weight and are still stigmatized against. Okay, and Jen, if you just want to advance the slide, there should be a section that pops up about implicit bias. And so implicit bias is more subtle, but can be just as problematic. It's more subconscious, automatic. It's ingrained deeply through our socialization, as I previously indicated. We know that implicit preferences predict our behaviors, such as tone of voice, facial expression, or our choice of words and attitudes in dealing with patients of larger body size. And there is research to show this starts early. So one such literature by Jennifer Herringer showed that girls by age 3 are already showing preference for thin people in pictures. Okay. We also know implicit preferences can influence our decision-making and is related to discrimination in other industries, such as hiring and promotion, medical treatments, of course, and decisions related to criminal justice. Next slide, please. Internalized weight bias is when a person applies these negative beliefs, attitudes, and stereotypes to themselves and are often engaging in self-blame for their own weight status. People who experience high weight bias internalization believe they deserve the negative attention, negative attitudes, negative treatment that they receive. But it's interesting that internalized weight bias occurs across the weight or BMI spectrum. So 44% of the general population, seemingly including all BMIs, even within what's considered typical or normal by traditional BMI standards of 20 to 25-ish, do still experience internalized weight bias. So it's not only an issue of patients in larger body sizes. And we're going to talk a little bit about some of the reasons for that coming up. However, patients living in larger bodies are more likely to report internalized weight bias or experiencing internalized weight bias, and that numbers are more like 52% of people in larger bodies experience internalized weight bias. Next slide. So not only does the research show that the prevalence of weight discrimination has increased over time, but the intensity of the discriminatory experiences has decreased, which I think is even more alarming. And so this would fall under our traditional understanding of, say, bullying in the schoolyard, or again by family and friends and just in the general population. Certainly children are not the only ones who experience bullying. It does occur as adults as well, unfortunately. So bullying, as well as audacious comments, and so just the boldness, the intensity of the discrimination people are experiencing. And I read a meme the other day that I thought was sort of appropriate here, where it said something to the effect of, be sure, or just a reminder to set firm boundaries, audacity is at an all-time high. So I think that kind of is sort of sums up the research in this area, that it is a bit alarming. Some of the other statistics in the literature show that higher weight people were significantly more likely to report discrimination in healthcare, and that 40% of adults report a history of experiencing some form of weight bias or stigma in general, so not just necessarily in healthcare, but in general. There is, however, extensive literature that documents weight bias and stigma across a range of health professionals, unfortunately. So this includes professional learners and trainees, and so physicians, nurses, dietitians, psychologists, kinesiologists, to name a few. This certainly isn't an exhaustive list of all the healthcare providers that are out there, but just to name a few. Next slide, please. Okay. So there's so much research to show the multiple negative impacts that weight bias and stigma has on health outcomes that's been studied, so much so that it was very overwhelming for me to compile it concisely for you. I was really struggling. But luckily, I came across some research by Poole et al., where they had already created this great handy schematic that does present it really well and perfectly, I'd say. So I'd like to take a few minutes and kind of go through this in some detail. So as we see, the weight stigma leads to stress, and stress has an impact on our eating and physical activity behavior. So we see higher levels of binge eating, increased caloric consumption in response, maladaptive weight control habits and behaviors, disordered eating, lower motivation for exercise, and less physical activity overall. There's also emerging research that suggests that the stress experienced from weight stigma and bias and discrimination can elicit a physiological reaction or stress response, causing increased release of cortisol, C-reactive protein, and increases in blood pressure, to name a few, which have been associated with increases in central adiposity around that midsection and increased risk of developing type 2 diabetes. We can also see the impact on healthcare service provision over to the right, leading to poor overall treatment adherence. Additional research by Alberga et al. Found that weight bias and stigma negatively affect patient engagement in healthcare through their perceived barriers to healthcare utilization, their expectation of differential treatment based on past experience, including the anticipation of more shame and blame, we call it, and low trust of healthcare providers or poor communication with healthcare providers. Okay. This leads to patients avoiding or delaying health services, including routine health screenings, follow-up care, and treatment. We also see the phenomenon of doctor shopping, which I've actually added myself to this slide, where we see people living at higher weight seeking a more empathetic healthcare provider. This leads to increased visits with different primary care providers, again, looking for someone who may understand them a little bit more, they may have a connection and experience less weight bias from, and also associated with increased visits to emergency departments. This has obvious detrimental implications to the idea of patients' continuity of care in the primary care model. As we follow this schematic a little lower down, we can see the effects on both psychological and physiological health outcomes, leading not only to weight gain, but increased rates of depression, anxiety, lower self-esteem, poorer body image, increased rates of substance abuse and suicidality, as well as overall increased cardiometabolic risk, more advanced and poorly controlled chronic disease, and lower health-related quality of life overall. So pretty significant, and I'm hoping that this slide summarizes for you the vast impact that weight bias and stigma has potentially on healthcare provision and outcomes. Next slide. Okay, so for the remainder of our session today, what I'd like to focus on are 6 strategies that you can specifically, hopefully fairly easily, implement to help reduce weight bias and stigma, which is the goal. The first strategy is to assess your own weight bias. Before you can assess your own weight bias, you need to acknowledge that weight bias exists within yourself and others. And so I have to admit, when I first was exposed to the idea of weight bias and stigma and first started learning about weight bias and stigma, and my interest was growing, I have to admit this was difficult for me at first to reconcile. The idea that I could have weight bias felt really contrast to my personality and my values of being kind and being an effective healthcare provider, you know, those types of things, which I think, again, come from probably some of the values by which I was raised, you know, to be a kind person, be helpful, you know, if you don't have anything nice to say about someone, don't say it, those kinds of things. And I'd even go as far as to say raised to sort of repress my own beliefs or opinions, particularly if they were controversial. So that's kind of where I come from. So recognizing or reconciling being a kind person and valuing being an effective healthcare provider with high expectations of my practice can coexist while I can understand the impact of systemic weight bias in our society. And so the old adage of once we know better, we should do better really applies here. I think it has helped me, again, to reconcile those two things into one, coexisting together. So acknowledging and reflecting on our implicit preferences, knowing that they can predict behaviors, checking in with yourself. There is a self-reflection test that I've included here, offered through the Harvard Project Implicit, the Weight Implicit Association Test it's called. It's free. It takes about 15 minutes to complete. I've done it several times, and I can share that although my, I guess, degree of demonstrated weight bias or implicit weight bias has decreased in the times that I've done it over probably the past 3 or 4 years. The goal is not necessarily to cure ourselves of our weight bias, but to acknowledge it, keep it in check, reflect, help reduce its impact on not only our beliefs and attitudes, but more importantly, our behaviors, not letting it impact our behaviors or decision-making, unbiased decision-making in the provision of equitable health care. So the link is there, however, easy to find in traditional search engines. Next slide, please. The second strategy, this is a busy slide here, is to avoid making assumptions about weight. And this is a biggie. So there is much outdated information and very outdated understanding of the pathophysiology of weight regulation. I am happy to announce that science has progressed to a new understanding of obesity as a prevalent, complex, progressive, relapsing chronic disease characterized by abnormal or excessive fat or adiposity that impairs health. Important to note that there's no mention of BMI under this new definition, as BMI has been proven time and time again to be not validated, unvalidated tool to predict health risk or assess health status. Okay. Also important to note that not everyone with a BMI over 30, which is sort of the older traditional view of defining or diagnosing obesity, is actually living with obesity as a chronic disease under this new definition. Okay, so that's a shift. And so, although I don't have time in this session to talk about the science of obesity as a chronic disease centered in the brain with complex interactions between the brain, gut, and adipose tissue, and defined by adipose tissue dysfunction and the importance of learning about adipose tissue dysfunction, I do encourage you to extend your knowledge beyond this session by reviewing the chapter on the Clinical Practice Guideline chapter on the science of obesity, which is a really easy read, very informative, and can be really helpful to sort of shift your understanding of, again, the pathophysiology of obesity. And anyone who works with me or anyone who will listen to me knows that I love the video you can find on YouTube called The Gatekeeper, Go-Getter, and Sleepy Executive by Dr. David Macklin. 9 minutes and 44 seconds. I've included a picture there of what you're looking for, but a really, I don't hate to use the word cute, but it's a really animated, easy way of understanding this new science and that it's centered in the brain. So I highly encourage that. So along with sorry, next slide, please. Just going ahead on my own here. So along with understanding the science of obesity comes the acknowledgement of the complexity of weight regulation and with the development of obesity. And this may help improve our approach to those living at higher weights or in larger bodies, okay? And may also help us to move towards more of a health-centric focus instead of a weight-centric focus. And again, that will shift or reduce those experiences of weight stigma for patients. With a reminder here that weight, or an important note that weight is not a behavior, should not be the target of behavior change if possible. It can be one of the possible outcomes, but trying to shift away from weight and a number to more kind of health focused and quality of life impacts. Avoiding oversimplified interventions and approaches such as eat less, move more, and ensuring to consider other factors impacting weight regulation that are out of that person's direct control. So obesity management should be based on the accepted principles of chronic disease management with a focus on health and quality of life, not weight. There is research to show that this is more motivating for patients and does lead to more sustainable change and improvements in health rather than just focusing on weight. The Edmonton Obesity Staging System I include there just sort of separately. It is a system, a staging system that considers the metabolic, physical, and psychological parameters to help determine impact of current body weight on health, and again, may be helpful in kind of assessing a patient's weight and how it's impacting their health. So I've included the link there, but also very easy to find through general searches. Next slide, please. The third strategy is to have sensitive conversations about weight, obesity, and obesity management. So we know through our previous review on the schematic that the approach by healthcare providers is a determinant to patient success, not only with behavior change, but with their experience, reducing their experience related to weight bias, stigma, and discrimination. So this includes its influence on our communication, verbal and nonverbal, as well as attitudes during our assessment and interactions with patients of higher body weight. Keeping in mind at all times with dealing with patients in larger bodies that they have likely experienced some form of weight bias, so to approach with empathy, be prepared to provide validation, and be mindful of, assess for internalized weight bias and stigma, because even if you're not, or you have checked and are reducing your impact of weight bias on a patient, they may be experiencing a high level of internalized weight bias on their own. And so it's important to keep an eye out for these types of things. So I have included some kind of formal assessment scales that are cited in the literature there that can be helpful. However, this can get easier to spot through discussion and assessment with patients directly. So sharing some of my kind of knowledge and experience, patients will often describe being disgusted by their body shape and size, and sometimes in particular a specific part of their body that they detest in particular. They often have unrealistic expectations for weight targets for themselves, as well as behavior targets. Sort of all or nothing thinking a lot of the times can exacerbate that. They are often not participating in life in some way. That's kind of broad, but for example, they may not allow pictures of themselves. They perceive they are unable to do certain things because of their weight, something as simple as even going out in public or socializing. They have a strong feeling that they cannot do that in order to sometimes protect themselves potentially against experiencing weight bias, and their experience of internalized weight bias preventing them. It can also be expressed as lack of kind of self-efficacy or confidence or certain abilities or skills because of their weight. So these are things that you can see through your interactions that they may share with you, particularly when they're more comfortable. And if you ask the right questions, what I find is a lot of times with patients who are living at higher weights or in larger bodies will describe a time where someone or multiple people have commented on their weight, positive or negative, okay, that was really internalized by them as being valued. And so certainly as experiences like this are increased in frequency, and particularly by those close to us, the intensity by which you're experiencing internalized weight bias can grow and be more intense. Next slide, please. So the 5 A's of obesity management is a framework designed as a step-by-step approach for busy non-obesity specialists who care for patients who are living in larger bodies or for those with obesity. It was first presented as a pilot study at Obesity Week in 2013, with the final results published suggesting that using the 5 A's framework facilitates effective and meaningful weight management in primary care. The INTERACT randomized controlled trial also showed that the use of 5 A's in weight counseling was associated with improved doctor-patient interaction and increased motivation to lose weight and manage their health. This framework has also been adapted for use in pediatrics, healthy pregnancies, and for team-based care. Again, although we could spend a whole session on the 5 A's as well, I think it's important to acknowledge the first step, which begins with asking for permission to discuss weight and exploring readiness of the patient. And this can assist with having more sensitive conversations about weight. Proceeding without permission or willingness from the patient to discuss their weight can contribute or does contribute to their experience of feeling stigmatized against for their weight. So that's important to be aware of. The other A's are in general here to assess obesity-related risks and root causes of obesity, to advise on health risks and treatment options, to agree on health outcomes and behavioral goals, not including weight as a behavior, and assist in accessing appropriate and, more importantly, evidence-based resources and providers. And so again, this is about a 5-minute video, I think, and so there's the YouTube link there, again, very easy to find just through general searches. Next slide, please. The fourth strategy is to endeavor to use non-stigmatizing language, words, and images. It's important to first note here that the preferred language is heavily debated by different groups, as there are varying paradigms by which weight stigma is viewed, okay? So for example, the word fat can be stigmatizing or can be seen as a neutral descriptor, similar to words like tall, short, thin. by, say, the HAES or Health at Every Size group, okay? But different people will have different word preferences, but acknowledging that for some people, words do matter. They can be very stigmatizing. Person-first language is promoted with many other disease states, such as diabetes, and is generally well accepted by all groups and recommended to be used when speaking about obesity. It's endorsed by the Obesity Canada, the Obesity Society, and Obesity Action Coalition. So, for example, sorry, I was going to say next slide, but before, this would include referring to someone as a person with obesity versus an obese person. Okay, next slide. We're going to look at here in this chart some weight-inclusive language. So, as I mentioned, words do matter. Eliminating kind of words and phrases such as morbid obesity, morbidly obese, extreme or super obese, to simply referring to obesity or an unhealthy weight, right? And as mentioned previously, avoid calling someone an obese person. If we're using person-first language, we want to identify a person living with obesity or a person living in a larger body, as again, not all people with a higher body mass index is experiencing obesity as a chronic disease. Okay. Weight recidivism should be replaced by behavioral recidivism. So I actually came across some old documentation of mine on a patient yesterday, so it's quite timely, from a few years ago, where I actually refer to a patient in my documentation as being at high risk for weight recidivism. So I had a giggle at my own kind of nerdiness in this area of how proud I am in that moment at how far I have come in terms of my own endeavors to use more weight-inclusive language. Next slide, please. So along with the non-stigmatizing language, words, and images, it shouldn't be new information for anyone that historically Western culture, media, diet industry promotes a thin ideal. This isn't new. There is much research linking negative societal attitudes about higher body weight people to negative portrayals of those people living in larger bodies in the media, popular culture, and even public health messaging is guilty of this. This is, of course, exacerbated by our pervasive and toxic diet industry. So making a conscious effort to use images that exemplify body diversity in our work, our presentations, our education materials is important in shifting perceptions and attitudes. I'd also like to note here that it's not only important when we're speaking about obesity or weight bias, or when using education materials specifically with those in higher body weights, but finding ways to incorporate these images into all that we do is important. And so this can include removing stigmatizing images from our waiting rooms and clinics, like subscriptions to certain magazines that promote this thin ideal. Will help not only those of larger body sizes feel more welcome, but people of average body size in that traditional sense. As we know, many of them are also experiencing internalized weight bias. Next slide, please. So many of the pictures I've used today in this presentation were deliberately taken from the Obesity Canada Image Bank, where they have a database with free access to images that, again, exemplify more body diversity and showing people in larger bodies doing a variety of different things to sort of normalize it. The Rudd Center for Food Policy and Obesity actually has quite a large media gallery database where you can actually search different categories if you're looking for something, a really specific type of picture in some of your work that you're doing or preparing. And there is additional media available through the European Association for the Study of Obesity, the Obesity Action Coalition, as well as the World Obesity Federation. Next slide, please. The fifth strategy is to check your clinical equipment and environment. So often clinics are not equipped with beds or chairs that can accommodate larger sizes or blood pressure cuffs that fit in order to get an accurate reading in your assessment of the patient. Imagine not having a clinic or hospital gown that covers your body entirely when you're asked to disrobe and in a vulnerable state, or having to stand to wait for your appointment sometimes for hours, because you were worried about how much the chairs in the waiting room will hold, or avoiding using the washroom even, because the reality is that many standard, even accessible bathroom stalls do not accommodate people of larger body size. So I've included some pictures here to show you there are different kind of chairs and beds available. There is equipment that does accommodate larger body sizes. So there's a couple pictures of chairs. The blue kind of vinyl chair depicted in the bottom picture there is more of a, I don't know, traditional view maybe of what a bariatric chair looks like, a lot wider, quite heavy. Some people refer to it as a love seat. I've had patients, want to sit on the love seat, right? It stands out a little bit more as being obviously a larger chair. The black vinyl chair depicted in the upper picture is blends in a little bit more. There's no arms notably on the chair, which many people find is more accommodating to fitting larger body sizes, but yet this is still a bariatric chair that can hold over 250, 300 pounds. So gowns are available for larger body sizes, exam tables with step stools in many cases to help access blood pressure cuffs, et cetera. I have the luxury of working in a clinic that was specifically designed for patients living in larger bodies, so we enjoy wider halls and doorways, including the bathroom has a floor-mounted toilet and other equipment that's specifically designed for larger body sizes. And patients have commented that it does help them feel less anxiety around their healthcare visits. Next slide, please. There is a clinical spaces checklist available that you can use to evaluate your own space. This is found in the clinical practice guidelines chapter called Enabling Participation in Activities of Daily Living for People Living with Obesity. And so it helps to ensure, again, that people are feeling safe, they're feeling respected within the space and decreasing anxiety. So it goes through the type of space, as mentioned, the waiting area, evaluating your reading materials, your posters and artwork that's displayed, as well as ensuring you have some bariatric chairs available. Examination rooms, so do you have an exam table that accommodates larger patients, a step stool if needed? Where is the weigh scale located? So is it private, out of view of other people, or the ability to pull at least a curtain or something around it for privacy? Though in terms of the washroom, the toilet, as I mentioned, a floor-mounted toilet is ideal, but imagine if you're asking for a urine sample, the difficulties that some patients may have in obtaining that without being able to have their weight accommodated. And then other equipment, as I mentioned, gowns, blood pressure cuffs, tape measures to do waist circumferences, for example. You want to ensure that you're planning ahead for these patients as much as you can to ensure that there is limited scrambling at the last minute, seeming unprepared or frustrated, which again will contribute to a patient's experience of feeling stigmatized or centered out. Next slide, please. And the last strategy is to empower the patient and include the patient's voice. So the idea of nothing about us without us, which is centered around this idea of patient-centered obesity care, which is really the patient is the center of all that should be the center of all that we do, including those of higher body weight. So we previously spoke of asking permission to speak about weight or talking about someone's weight, but also asking permission to weigh someone can go a long way in demonstrating understanding of how sensitive the number on the scale can be for people, as well as evaluating if you need to weigh someone right away. And I reflect on my own training as a dietitian many years ago where, it was always just part of the routine assessment that you weighed someone first before an assessment. So especially if it's the first interaction with someone, you don't need to necessarily weigh them immediately. I would encourage you to consider doing it later once you've built rapport and the patient feels safer. It also sets the tone that weight is not going to be at the forefront of everything that you're doing with them. Also ensuring privacy is important when weighing, asking permission, again, to weigh them, and making it okay for them to decline if they don't want to. They may want to next time. There may be other opportunities. It's not necessarily crucial that you obtain that number most of the time, okay? Engaging the patient's voice. So asking questions, but also taking the time to listen to patients' experiences and validating their experiences. Patients in larger bodies are keenly aware that they are in larger bodies and that, again, many have already experienced weight stigma. They've been told that there's something wrong, inherently wrong with their bodies, seemingly for some people for their entire lives. So empowering patients to cope with stigmatizing situations, and informing them, encouraging them to attain high-quality health care. Again, this is an opportunity to assess for internalized weight bias, as many patients who experience internalized weight bias don't believe they deserve high-quality health care. This is their own doing, their own fault. They don't deserve that type of respect and quality health care that may be unto others as more of a thin, fit privilege. Okay. Advocating, speaking up, supporting policy action, and creating supportive healthcare environments all fall under this category as well. And further to this, you know, we live in a culture that normalizes this fat jokes, comments about weight, which really sets to demoralize patients and perpetuate bias further. So further laughing at these things endorses the beliefs in these biases. So informing someone, calling someone on their jokes or behaviors that do contribute to weight bias can help in changing that narrative and at least inform that you don't tolerate that and that your expectations are different and that you believe in weight stigma as important in our healthcare environment, okay? And in addition to that, I'd love to see away with anyone commenting on anyone's body weight, positive or negative. We should never be commenting on anyone's body size. I just think that further contributes significantly to weight bias and stigma. Next slide, please. Some other contributing factors is that certainly there is a lack of training for healthcare professionals in this area. Historical models in healthcare training do not include anything related to this type of training. And studies do suggest that incorporating weight sensitivity training can go a long way in reducing explicit weight bias into professional curricula. The reality is many healthcare professionals, researchers, policymakers, and general public are predominantly unaware of the changing definitions of obesity and weight stigma as a health issue. But research does remain fairly premature as to whether adopting obesity as a chronic disease will significantly reduce weight bias and stigma. That's yet to be seen, but I am hopeful and believe in that. And there are a lack of laws and policies to protect patients against weight stigma and to further prevent it. Next slide. To that end, there is some efforts to implement individual and societal change, including efforts by the Association of American Medical Colleges to roll out new diversity, equity, and inclusion standards aimed at teaching doctors, among other things, respectful treatment of patients at higher body weights. In Canada, we see the Balanced View online program launched in 2015 for healthcare professionals aimed at reducing weight stigma. And Alberta Health Services launched the first bariatric-friendly hospital initiative in 2019 with the goal of reducing weight bias by improving patient-client experience and staff training for those caring for bariatric patients. The Bust the Bias series is, I think, 5 to 6 short educational videos offered through Obesity Canada, aimed to provide research and evidence-based information to reduce misconceptions about obesity in general. Next slide. In summary, I hope that it's clear to you all that weight bias and stigma does exist in healthcare settings and can negatively impact health outcomes. The new science redefining our understanding of obesity as a chronic disease challenges the prevailing belief that body weight is 100% within direct personal control, which may contribute to our biased beliefs in that area. And strategies do exist that can be implemented without extensive education and training, such as we've discussed today, acknowledging, assessing, and addressing your personal bias, avoiding making assumptions about weight, having more sensitive conversations, endeavoring to use non-stigmatizing language, words, and images, checking your clinical equipment and environment to ensure that it promotes inclusion and accessibility, and empowering the patient to include their voice, again, in all that we do. I want to circle back quickly to the 2020 Canadian Adult Obesity Clinical Practice Guidelines. These are a much-needed evidence-based, patient-centered framework to inform professionals, patients, and policymakers. This is the first comprehensive update in Canadian obesity guidelines since 2007, and the most extensive review of published evidence yet in obesity worldwide. There's 19 chapters that I've included here. They are fairly short and concise and easy to read, and they do include many key messages to all policymakers, healthcare providers, and patients alike, and can be found on the Obesity Canada website. Quick shameless plug for Project Echo Bariatric, which provides education and support targeting healthcare professionals, increasing their knowledge. It's free, fully funded by the Ontario Ministry of Health, and there's a session starting next week or the week after, and you can get dates and details of how to register on their website. And hopefully we didn't delay too much, and I've left some time for to address some questions, and I thank you very much for your attention and attendance today.
Thank you, Sarah. If anybody would like to put any questions in the chat, feel free to do so, or take yourself off of mute. We'd love to hear from you.
So Jen, there was the first question from Kim, just asking about, Sarah, whether or not you'd feel comfortable sharing slides that we could distribute to the participants afterwards.
Oh, sure. Yeah, absolutely.
That's great. Thank you. And then there was a second question from Ashley. Ashley's asking, doesn't pathologizing bodies and promoting the intentional pursuit of weight loss run counter to reducing weight stigma?
Sorry, I couldn't hear that very well. Can you repeat that one more time?
Yep, sorry. Doesn't pathologizing bodies and promoting the intentional pursuit of weight loss run counter to reducing weight stigma?
Runs counter to reducing weight stigma. That's a great question. I think I understand. I think I get it. I heard it a little bit better there. I think what you want to be careful with is that, again, that you're asking permission. So I think this idea of over-pathologizing weight comes from our assertion, our aggressive assertion at times, that patients are obese and have problems with their health, when in fact that there may not be any evidence to that. So I think over-pathologizing it without any evidence that it's actually impacting their health, or purely using body mass index, does contribute to weight bias and stigma. So the importance is changing our views around how we assess body weight and its impact on health. And again, we could have a full session on the assessment of obesity, how we assess, and the science of obesity. But I would agree with that, yes. So over-pathologizing weight and over-pursuit of weight loss does contribute to weight stigma. And so further to that, I'm having another thought, that you will experience in your practice patients who, because of likely high levels of internalized weight bias, really believe that weight loss is the only way for them to improve any improvements in their quality of life or health. So it's important for us as healthcare providers to make sure that we're informing them appropriately that this dichotomy between older views of body mass index and this new definition of obesity, that again, not all BMIs or people in larger bodies are experiencing obesity as a chronic disease, but we are working in a healthcare system that definitely over-pathologizes the concern of BMI, sometimes in the absence of any other health conditions being present and rationale for weight loss. And so other than the doctor or whoever believing that that is the way to improve their health, it's misinformed. So I hope that answers that question.
Thank you. Nicole also says doorways can be a good one to be aware of. Some wheelchairs may not fit through, limiting access to service in areas.
Absolutely. And so I think about even our clinic here within the medical center building that's adjacent to the hospital site. Although our clinic is been sort of retrofitted or designed specifically with those patients in mind, access to the building at large does not. So I believe our bariatric wheelchairs do not fit through the doorway of the lobby or whatever you'd call it. So that's definitely an accessibility issue.
Yes, and Kendra also asked, do you have any suggestions on where to source appropriate equipment, such as blood pressure cuffs and chairs?
Ooh, I don't off the top of my head, but I could look. I could certainly, well, what I would say is I would reference that chapter that I talked about, the enabling participation of activities of daily living in the clinical practice guidelines. So Mary Forhan, who is featured in one of those pictures from those slides, is an occupational therapist as well by trade, but she's like the research director at Obesity Canada. She has quite a high position. She's very passionate about that exact issue. So that chapter would probably be where I would go. I would look through the references, and perhaps even within the chapter itself does talk about that. So I would start there for sure.
Thank you, Sarah. And just to let everyone know, I will share the slides with everybody present today, if that's okay with Sarah. We also have, Aaron has asked, building on previous question, is obesity still considered a chronic disease, or does this depend?
Well, that's a great question. I feel like I could build a whole presentation on that. So obesity can be considered a chronic disease. It depends on our definition of obesity. So again, like I said, going back to our traditional view of what defining obesity as a BMI over 30, all people at a BMI of 30 or even 35, doesn't matter what number you choose, are not living with obesity as a chronic disease. And so that's where I would encourage you to take a look at the Edmonton obesity staging system that I referred to. Again, we could do a whole presentation on that, on how to use that, but it does take into account the different impacts of a patient's current weight beyond their BMI and how it's impacting their current health. So that is what I would use more to define if obesity, in that traditional sense, is an issue. And so, again, patients will often be misinformed or confused because a lot of their identity is tied up in their self-image and their experience of internalized weight bias. And so referring to that Edmonton obesity staging system, I think would really be helpful when you're taking a look at someone's body weight and whether they're experiencing as a chronic disease. And I would say when you look at it, it should be clear, but there's 5 stages. They've done away with, I think, stage 0. So I think it maybe is down to 4 stages. But stage 2 and up is where we would start to see their weight impacting them in terms of a chronic disease. And so I, again, would refer you back to that staging system for more information there on how to define that.
Thanks, Sarah. There's one more question from Becky. She says, while living in a larger body may not be a health issue at present, what about preventing of future health issues? I'm thinking specifically of joint protection, i.e. prevention of early onset osteoarthritis.
Right. And so I agree, definitely. And I think this is where you have to individualize your treatment and where a full assessment in terms of family history, genetic history maybe is warranted and may help to give you more information here. However, there is, again, information on the prevention and harm reduction of obesity, where you can get, again, clinical prevention that does talk about that in one of the chapters. Because I agree, there are certain time points over the course of a lifespan that may put patients at higher risk at times of gaining weight. So I think of things like pregnancy, starting certain medications, to name a few. that can influence that set point, that metabolic cascade that can happen. But certainly prevention is key. So starting with limiting further weight gain and focusing on behaviors that the patient is within their control to change. So that's where acknowledging the multiple factors, some of which are out of the patient's control, that need to also be controlled for. And that's where some of these obesity treatment guidelines can help inform how we should be addressing that with patients. But I do agree, prevention is also key in those at high risk of developing obesity.
Thank you, Sarah. We don't have any other questions. Any other questions? I'd just like to say thank you so much. Oh, one other quick one came in from Ashley. Important to note that correlation is not causation. While higher weight might be associated with OA, it doesn't mean that this causes it, and it doesn't mean that patients have the ability to change their weight.
That's right. Preach.
Thanks, Ashley. Yes. So Sarah, we'd like to thank you again. Everybody is saying great presentation. Thank you. And I do apologize, everyone, for the technical issues, but of course, this is the world we live in.
Yeah.
So thank you again. And we will be sharing the slides with everyone.
Great. Thank you so much for having me. Thanks for participating, everybody. Great questions.
Have a wonderful afternoon, everyone.